Without further ado, I'd like to introduce our first speaker of the day, Dr. Leah Croll, who's going to talk about stroke in women. Dr. Croll is a new addition to our program since last year. She's currently an assistant professor of neurology at SUNY Downstate Health Science University and attending neurologist at Maimonides Medical Center. She completed her neurology residency and stroke fellowship at NYU Langone Health. Dr. Croll is board certified in both neurology and vascular neurology, and her clinical interests include women's neurology and lifestyle medicine. Aside from clinical practice in neurology, she's also a medical journalist. She has covered a broad range of health and neuroscience stories, including FDA approvals, breaking news research, changes to NFL concussion protocols, groundbreaking therapeutics for Alzheimer's disease, even Elon Musk Neuralink, and COVID trends. So Dr. Croll is a frequent guest medical expert for multiple media outlets. She has appeared on the BBC, Good Morning America, ABC News Live, World News Tonight, and David Moore, and more. She's our multimedia mogul. So welcome, Dr. Leah Croll.
Okay, thank you, Tony, for that very generous introduction. I'm Leah. I am thrilled to have joined the program and even more thrilled that I get to talk about this topic, which is so near and dear to my heart today. Also, as an aside, it's a great excuse to use magenta slides in a professional setting, so that's a lifelong dream for me as well. Thank you for that. I know that we were going to have some audience participation questions. Tony, did we have like a online QR code that we were supposed to show? Okay. Yeah. Thanks, Raina. Okay. All right. So just a couple of quick questions to sort of take a temperature in the room. Having a history of which of the following conditions increases a female's risk for stroke: preeclampsia, early menarche, early menopause, endometriosis, or some combination of those? I'm not sure how we're going to see the online responses. Maybe I'm seeing an F in the chat. Any other people want to chime in? G. Okay, I'm hearing a lot of F and G, but the answer is actually going to be H, all of the above. So these are all important vascular risk factors for women. And in pregnancy specifically, pregnancy increases the risk for which of the following cerebrovascular diseases: cerebral venous sinus thrombosis, cervical artery dissection, cardioembolism, aneurysmal hemorrhage, or some combination of the above? Yeah, everyone's getting this one. It's definitely all of the above. So great. Let's jump into it. So women's health is so much more than obstetrics and pap smears, and it spans the entire female lifespan. So when it comes to cardiovascular health, when it comes to stroke, women are not simply men in smaller bodies. It's much more complex and nuanced than that. There are important sex differences that we'll go over that influence risk for stroke and stroke outcomes. And I think it's absolutely essential that we raise awareness of this within our community so that we can improve the way we screen patients for vascular risk, counsel patients on their vascular risk, and really tailor our prevention strategies in a more effective manner. Sex differences also exist in the way that stroke presents in women and the likelihood that women are presenting with a stroke mimic, which I want to highlight as an important point because we often talk about this in cardiology. We speak of non-traditional heart attack symptoms that women may present with, but we don't talk about it enough in stroke, and the same sort of principle applies here. So we'll talk about all of this. Just going over some important sex differences in epidemiology here. So women are more likely than men to have stroke. In fact, stroke is the third leading cause of death for women in the United States. 1 in 5 American women will have a stroke in their lifetime. And every year, about 55,000 more women than men have a stroke. Often women are familiar with that number. 1 in 8 will have breast cancer in their lifetime. The 1 in 5 number about having a stroke is something that's less well known. Women are also often surprised to learn that every year twice as many women die of breast cancer as, of stroke as they do of breast cancer. So again, something we need to raise awareness for, not only within the medical community, but on a public health level as well. And you know, this all boils down to basically 2 things. Women live longer than men, and they also have a higher lifetime risk for stroke, 17% in women after 50 versus 15% in men after 50. This graph on the left is showing us the incidence of stroke by gender over time. And we can see that since about 2000, stroke incidence has been steadily declining in men. But since about 2005, we're seeing an uptick in women. So that's definitely an area for concern. And on the right, we see an important differentiation when it comes to age brackets. So up until about 59, men and women really have a similar risk for stroke. Between 60 and 79, stroke is far more prevalent in men. And after 80, it's far more prevalent in women. One of the reasons, or one sort of facet of a woman's elevated risk for stroke, is the fact that traditional vascular risk factors impact female stroke risk more than male stroke risk. So starting with prevalence of some important vascular risk factors, hypertension in older age is more common in women, migraine is more common in women, obesity is more common in women, depression, anxiety, and physical inactivity also more common in women than men. Some of these vascular risk factors have been shown in the literature to have a more close association with female stroke risk than male stroke risk, so that encompasses hypertension, diabetes, AFib, migraine, and smoking. In fact, some studies have estimated that a woman's risk for stroke from AFib is almost double that of a man's risk for stroke from AFib. Women are also less likely than men to be treated with oral anticoagulation. They're less likely to be treated with statins, but they're more likely to have important procedural complications like complications from catheter ablation for AFib or left atrial appendage closure. Okay. The other important piece to a woman's elevated risk are her unique and often unrecognized biologic risk factors for stroke. So throughout the female lifespan, there's a number of hormonal factors that come into play and change over time. And we really need to do a better job of screening women for this. So in the childbearing age group, the age of menarche is an important risk factor to think about. Having early menarche, 10 years old or younger, actually is associated with a 25% increased risk for stroke later on in life. Endometriosis is an extremely common condition among women. 1 in 10 women have endometriosis. Many experts in OBGYN say this is likely a gross underestimate because it's such a tricky and challenging diagnosis to make. But the relevance here is that it's a highly inflammatory condition. It's a known vascular risk factor. And in fact, in the latest 2024 iteration of the American Heart Association's primary prevention guidelines, they specifically mention endometriosis as an important risk factor for women. Migraine with aura, as we already mentioned, is more common in women. And also women in this age group may be on estrogen-containing oral contraceptives, which of course increase risk for stroke by about a factor of 2. Pregnancy and the postpartum period in and of themselves carry an increased risk for stroke, but many of us may not keep in mind that having complications during pregnancy can also increase risk for stroke later on in life. So that particularly applies to hypertensive disorders of pregnancy. That's your gestational hypertension, preeclampsia, and eclampsia, but also applies to preterm birth, gestational diabetes, and placental disorders. And then menopause is another important period for vascular risk. So women with premature ovarian failure before 40, early menopause before 45, they have increased risk for stroke later on in life. And many of these women are on hormone replacement therapy, which is fine for most, but for a minority of women on hormone replacement therapy, specifically those over 60 and more than 10 years out from natural menopause, that hormone replacement will actually increase their risk for stroke. I want to take a little bit of a closer look at pregnancy-related risk factors. So I think many of us are more than familiar with this idea that pregnant and postpartum women are at an elevated risk for multiple vascular events. Certainly, pregnant and postpartum women have a 3 times higher risk for stroke versus age-matched young adults. But again, I want to highlight that complications from hypertensive disorders of pregnancy can increase risk for multiple vascular complications later in life. Specifically, women with a hypertensive disorder of pregnancy will have an 80% increased risk for stroke later in life. They also have increased risk for hypertension, CAD, heart failure, and cerebral microvascular disease. So this is part of why we see elevated rates of dementia in women as well. Pregnancy-associated stroke, also known as maternal stroke, has an incidence of about 30 per 100,000 deliveries, but important to know we're seeing steady increases in this over the last 30 years, especially in that postpartum period. In New York, 1 in 5 strokes in women under 35 was pregnancy-associated, and these strokes can be devastating because half of them are hemorrhagic. Some of the more common causes of stroke in pregnancy: preeclampsia, eclampsia, HELLP syndrome, cardioembolism. But there's really a number of stroke mechanisms that pregnant women are at high risk for. So hypertensive hemorrhage, a vasculopathy known as reversible cerebral vasoconstriction syndrome, cerebral arterial dissection, cerebral venous thrombosis. They have coagulopathy that can produce stroke, cardioembolism we mentioned. Women can have stroke from amniotic fluid embolism, although that is extremely rare. And then women who have pre-existing vascular lesions like an AVM or an aneurysm are more likely to become symptomatic from those lesions in pregnancy and the postpartum period. So zooming in a bit on the physiology that underlies this, in a normal, healthy pregnancy, there are important hemodynamic changes that go on. There's a huge increase in intravascular volume, a 45% increase in cardiac output. So a lot of people sort of liken this to a stress test on your heart and vascular system. But those sort of fluctuations in hemodynamics are what make women potentially more at risk for developing hypertension, for developing venous clots, for rupturing underlying vascular malformations. Meanwhile, also in a normal pregnancy, the production of a number of clotting factors increases, as does the production of a number of inflammatory factors. So again, contributing to a hypercoagulable state. And then in terms of those pathological conditions in pregnancy, you can have cardiac remodeling that goes wrong. We call it peripartum cardiomyopathy. These are women who get cardioembolic stroke from that. And of course, women with hypertensive disorders of pregnancy, extremely important for us in the stroke neurology field to be aware that they have endothelial dysfunction, they have disruption of the blood-brain barrier, and they have impaired cerebral autoregulation. So that's why these women are commonly getting PRES, getting reversible cerebral vasoconstriction syndrome, getting cervical artery dissection. Okay, I'll sort of briefly run over acute stroke imaging and treatment in pregnancy. Often there's trepidation around exposing the fetus to radiation. In general, CT head is considered to be totally acceptable in all trimesters in the postpartum period if there's concern for acute neurologic changes. CTA and CT perfusion, we are a little pickier about. Number one, it's more radiation. Number two, CT contrast does cross the placenta, and it's not clear if it's toxic to the fetus. So certainly it's worthwhile to get it if there's high concern for a large vessel occlusion. Otherwise, you can wait for the MRI. Keep in mind, MRI is great. There's no radiation. You don't want to give gadolinium during pregnancy. It does cross the placenta. It is toxic to the fetus. Breastfeeding women can get gadolinium, but it needs to be a risk-benefits discussion because it does come out in trace amounts in the breast milk. So often we recommend that they pump and dump for a day or two after getting an MRI with contrast. I'm going to refer to TPA, not TNK, in this talk. Of course, these days we're using TNK for the acute treatment of stroke, but the literature hasn't caught up yet for pregnant women, so most of the literature still deals with TPA. Pregnancy is not a hard and fast contraindication to TPA. The key is really to engage in multidisciplinary discussions with the stroke team, the MFM team, and the neuro-IR team. Just so you know, TPA doesn't cross the placenta, so it's actually not fetal risk we worry about. It's more maternal bleeding risk. And women are at highest risk for this bleeding in the immediate postpartum period, so that first 48 hours after delivery. Pregnant women can undergo endovascular thrombectomy. We can do abdominal shielding to try and minimize the radiation exposure for the fetus. And some experts are advocates for skipping TPA if a pregnant woman is going to go for thrombectomy. Managing hemorrhagic stroke in a pregnant patient is no different than any other patient. Immediately, we're focused on blood pressure control, and we do want to use imaging to determine if there's a symptomatic vascular malformation that needs to be addressed. Okay. So I'm going to get on my little soapbox for just a second. I think menopause is getting a lot of attention in the media right now. But keep in mind, the reason it's getting attention in the media is because it's sort of woefully understudied and underappreciated in our field. I, for one, am not that old, and I remember having exactly one hour lecture on menopause in medical school. Then it never came up again, not in my clerkships, not in my residency, not in my fellowship. And that's really a shame because over half of our population are women, and nearly all women will spend more than 1/3 of their life in menopause. So there's really a movement going on a public health level and within the medical community as well to raise awareness about what menopause really is, which is a complex set of physiologic changes. It is not just your period stop. And the reason that this is important for us in this lecture is that while we usually think of estrogen as carrying risk for thromboembolic events, which is true, it also seems to have a protective role on the health of our blood vessels. And so women who have earlier menopause live more of their life in an estrogen-deprived state, and that increases their risk for stroke later on in life. Reproductive lifespan is sort of a term that we use in the literature and something you may hear the OBGYNs use to talk about this concept. So the lifespan basically is the age of menopause minus the age of menarche, and women who have a reproductive lifespan less than 30 years long have higher stroke risk for two reasons. Number one, as we mentioned before, it's less time exposed to that endogenous estrogen, but number two, they're also much higher risk for higher risk lipid profiles. Menopause has many, many symptoms. This isn't a menopause lecture, so we won't go over all of them, but I do want to highlight one group, which is vasomotor symptoms. These are the hot flashes and night sweats that women experience. It's very common. Over 80% of women in menopause will experience this. And the reason it's important for us to talk about them is because they are associated with increased risk for heart disease and stroke. And they're also associated with other factors that compound cardiovascular risk, like high blood pressure, hyperlipidemia, poor sleep, anxiety, depression. So certainly when we're counseling patients about cardiovascular risk, important to take that into account. The other reason I'm highlighting vasomotor symptoms is they're the most common reason that a woman would be started on hormone replacement therapy. I'm sure many of us are aware that there's been an awful lot of controversy over the years about the use of hormone replacement therapy for menopausal women. I'm going to go ahead and summarize that in one statement, which is that the vast majority of women actually are great candidates for hormone replacement therapy. A very small minority are not good candidates for hormone replacement therapy. What we need to know about it is this: using hormone replacement therapy within 10 years of the last period is very low risk. Those women do not seem to have an increased risk for thromboembolism. However, after that 10-year period, that's when we start to worry about increased risk for stroke. There are some women that at baseline, of course, have higher cardiovascular risk. So some recommendations use the Framingham risk score to help us risk stratify patients. But I think for us in this talk, what we need to know is that you don't necessarily have to use oral estrogen. You can use transdermal estrogen, which is safer and less associated with thromboembolic events for these women. I would be remiss in a lecture on stroke in women not to mention cerebral venous sinus thrombosis. For those of us who aren't neurologists, this is a rare type of stroke. It's a DVT of the brain. Really, it's less than 1% of all strokes, but it's 3 times more likely in women, and specifically in young women. About 80% of affected patients are under 50. Now, some people can get cerebral venous sinus thrombosis from your regular, plain old hypercoagulable states, genetic thrombophilias, cancers, antiphospholipid, but young women are at risk for some acquired triggers like pregnancy, the postpartum period, and exogenous estrogen. The good news is that for young women with CVST, with sex-specific risk factors, they have a far better prognosis than men or older women. And just as a quick reminder, during pregnancy, the treatment for this is with Lovenox. And sometimes we're asked if a woman has a history of CVST, is that a contraindication to pregnancy in the future? It's not. She just needs to take Lovenox throughout her pregnancy. Okay, I saved sex differences in stroke presentation for the end. Again, because the cardiologists are doing a really good job, I think, of raising awareness for non-traditional heart attack symptoms in women, and we need to do a better job for raising awareness of non-traditional stroke symptoms in women. Now, to be clear, motor and speech deficits are the most frequent presenting stroke symptoms for both men and women. The problem is that women are more likely than men to also have these non-traditional sort of vague stroke symptoms like altered mental status, headache, fatigue, lightheadedness, and nausea. Women are also more likely to present with stroke mimics. These are conditions that may look like stroke, but they're not actually an underlying stroke. So examples are complicated migraines, seizures, metabolic disturbances, and functional neurologic disorders. I will add here that literature has shown that female providers are just as likely as male providers to misdiagnose a female patient with a functional neurologic disorder. So super important for all of us that we try and keep this in the back of our minds when we're evaluating these patients. We never want to miss an opportunity for stroke treatment. We know time is of the essence. We know it's dangerous to lose time when we evaluate these patients. So really making sure that you're taking them seriously is of the utmost importance. Stroke outcomes in women are generally less favorable than stroke outcomes in men. Most of this is due to two reasons. Number one, women are older at the time of their stroke. And number two, women tend to have a worsened pre-stroke functional status compared to men. That being said, overall mortality is higher for women. They're less likely to have a good functional recovery, less likely to have a good quality of life. A lot of that has to do not only with functional recovery, but the fact that women are more likely to be living alone when they're older and having a stroke. And usually the woman is the caregiver, but may not have caregivers in her life to take care of her. Women are also at higher risk for post-stroke depression and post-stroke cognitive impairment. So in conclusion, stroke really is a women's health issue. It is under-recognized and underappreciated as a women's health issue. It affects women differently than men, primarily because of their unique biology and longer lifespan. And it's just absolutely essential that we do a better job of integrating this into our assessments and our prevention strategies. We should also keep in mind that women can have more confusing presenting symptoms and mimics, and that those things can cause delays in the acute stroke evaluation, which can be very dangerous. Women do have poor outcomes from stroke. It's mostly influenced by older age and pre-stroke functional status, but that doesn't mean we should give up. That means we should really tailor treatment, personalize it in the hopes of improving those outcomes for women. These are my references. Thank you.
Thank you, Leah. That's great. We have time for a few questions. Anybody in the audience has any questions before we go online to check the questions online? Great talk. Thank you. So if you're seeing a woman in the clinic that has never had strokes before, and she's asking you for advice on measures that she would do to reduce the risk, what are the typical profile factors other than the typical risk factor we know for everyone, hypertension, diabetes, and smoking, so on and so forth? What are the things specific for women you would recommend for them to do or not to do?
Great question. So really the first step is educating them about their sex-specific risk factors and doing a screen for, do they have a history of preeclampsia? When did they get their period? Do they have a history of endometriosis? These sorts of things, because that really helps us understand what their risk for cardiovascular events looks like. And then once we have a good sense of what their risk is, we can work with the OBGYNs to advise on basically whether or not they're safe for certain things like oral contraceptives or hormone replacement therapy, and also what sorts of lifestyle modifications and medical management they may need to work with their vascular risk. I also do lifestyle medicine, so one thing that I am going to be working on with the OBGYNs when we open our women's neurology center in the next month or two are going to be specifically resistance training programs aimed at helping women optimize their brain health, nutrition for brain health, and sleep and stress management strategies for brain health too.
Any additional questions? We don't see anything online, so I'll take the time. So what are the measures that you see or have seen that's been taken by the society or our field to systematically move women's issue, such as menopause and things in a direction? What are the concerted efforts you have seen?
Well, I think right now, when we're talking about vascular risk for any patient, it's not sex specific, at least in the stroke field. We're often not talking about that unless a young woman comes in and we're asking if she's on birth control. Beyond that, I don't think we're asking about history of hypertensive disorder of pregnancy. We're not asking about gynecologic histories. So, I would like to see our field do a better job of educating within it about what we need to be asking about. And I also think that we don't emphasize enough primary prevention or the lifestyle modifications that go along with secondary prevention strategies. And I think those are, particularly applicable to women because we know that women are more likely to adopt lifestyle modifications. They're also less likely to be regularly seeing a healthcare provider and staying on top of things like high blood pressure, often because they're busy caring for others in their life.
Are there any current clinical studies related to stroke in women?
Sorry?
So the first question, is there an assessment tool to use in primary care to identify risk factors?
I'm not aware of any sex-specific assessment tools. Obviously, the Framingham risk score is the one that we use, but I am not aware as of yet that there's a widely employed female-specific tool.
Any current clinical studies related to stroke in women?
I'm not aware of any clinical trials going on right now. Hopefully in the future.
That's such a big void. Any comments, Dr. Levine or Dr. Elkin in the audience about women's studies in stroke?
Wonderful talk, Leah. Thank you so much. I've always been fascinated because this data is quite old, and I don't know if there's been any thinking about basis, mechanism, or thought. But when they did the physician's health study, which was men, primary prevention with aspirin, they found reduced risk of heart attack, not help with stroke. In fact, the value of 0.06 for hemorrhagic stroke, so very strong trend for bleeding. Nurses study, which is sort of the equivalent, they actually found a statistically significant benefit in stroke prevention for women, but not in men. And I'm just curious, with aspirin effects, do you have any insight from what you've been, studying? And because I am not sure I can understand.
Yeah. My honest answer to this question is there's no definite data that I use as a guide. It's just an understudied area for women, of course. But there are certain cases where I've discussed with GYNs if we're, worried about a woman or if she really needs hormonal replacement therapy for certain menopause symptoms, but also has vascular risk, we might choose to empirically start an aspirin. But as far as I'm aware, there's not guidelines on this.
Thank you.
The other one. Yeah. So I was just going to make a point about risk prediction in people in general, including women. You mentioned the Framingham risk score, and there are others, but the American Heart Association about a year or so ago released a new risk prediction scheme called Prevent, designed to include some other risk factors like kidney disease, which had traditionally been left out. It predicts heart failure. It predicts risk in younger people, so starting at age 30 through 79, and it predicts 10 and 30-year risks, and has been validated in over 3 million people from electronic health records, so real, like real patient data. And so people might want to use that and that to predict risk. And then the idea in primary prevention is often to use the absolute level of risk, and not just of stroke, because People don't know what they're going to have until it happens. Could be stroke, heart attack, and so forth. And so the risk of that composite of events, and if it's above a certain threshold, perhaps 10% over 20 years, then recommend antiplatelet therapy. So I guess I would say regarding aspirin, it's probably not for everybody, as Dr. Levine was saying, but in particularly high-risk people because of a composite of different risk factors, and it may differ for men and women, then there would be a reason for doing that. So just throwing that in there. Thanks.
Wonderful insights. Thank you so much.
So besides the aspirin question, are there any other evidence of inequality of acute stroke between women and men?
Yeah, so most of this inequity really manifests in the time for evaluation. So as I mentioned before, women are less likely to be recognized immediately as having stroke and more likely to miss important treatment windows. So that's where a lot of the inequity lies. There is research about poor outcomes, obviously, in women with stroke. But again, most of that, when you adjust for age and pre-stroke functional status, sort of comes out in the wash. So it seems to be mostly about recognizing in the acute phase.
Great. So Annie asked a question. So provide education to the patient is an integral part of your stroke care, and this is important, especially in an outpatient setting. What are some strategies you suggest regarding not scaring the patient too much so they don't come back to see you again? Or risk of stroke, future stroke, given all the shared risk factors affecting all women?
I will tell you what I tell my patients in the clinic and also what I talk about on TV and things like this, which is that I think in breast cancer, women have this great understanding of the importance of prevention. They're motivated to get their screening mammograms by and large. They're aware of how common breast cancer is. And I encourage female patients to think of their cardiovascular and stroke risk in the same vein, that they need to be seeing their doctor at least once a year, checking in on their risk factors, screening for any new risks that may come up, and managing that risk accordingly. So sort of framing it really in that prevention mindset is important. And I find that that analogy to breast cancer helps a lot of patients understand that approach.
Great, thank you. One last question. What's the effect of plant hormone on stroke, such as daily soy milk, since more people become vegetarian and vegan?
It's a good question. Right now, there's not literature that suggests that this is a relevant stroke risk. But certainly, I think, as far as I can tell, amongst the plant-based community, an area of interest. So maybe a study down the line.
Thank you.
Thank you.